Hello everyone, I'm Dr. Vishnu Mohan, Secretary of NNF Kerala and Organizing Secretary of IEP Neocon 2021. I have great pleasure in welcoming you all to the 14th webinar of our international webinar series. It's great to have all of you with us, nearly 2,500 registrants from 65 countries all over. Welcome dear friends to the 14th session of Learn from the Legends. We have with us two eminent neonatologists of our country, Dr. Surya Narayana Noori from Vijayawada and Dr. Preeta Joshi from Mumbai to moderate today's session. Welcome, Madam and Sir. And let me welcome our legends for the day, Dr. Manoj Malviya and Dr. Prakash Manikoth. Dr. Manoj Malviya is working as a senior consultant in neonatology at Kola Hospital, Muscat. He graduated from Government Medical College, Nagpur and completed his post-graduation in pediatrics from the same institution. He earned his MRCP from UK and underwent 2 neonatal fellowships, initially at Hospital for Sick Children, Toronto, Canada, and from Westmead Hospital, Sydney, Australia. He is a senior consultant neonatologist at Kola Hospital, and he has published various articles in peer-reviewed journals and authored 5 Cochrane database of systematic reviews, including one on PDA. He has contributed 2 chapters in Essential of Neonatal Ventilation by Dr. Rajiv Vidyasagar et al. His academic interests include NICU infection control, quality improvement, and non-invasive ventilation. Welcome, dear sir, for today's session. The second speaker for the day is Dr. Prakash Manikoth. He works as consultant in neonatology at Armed Forces Hospital in Muscat, Oman. So graduated from Calicut Medical College and completed his post-graduation from the Institute of Maternal and Child Health attached to the same college. He earned his MRCP from UK and is a fellow of the Royal College of Pediatrics and Child Health UK. He was a consultant neonatologist at Royal Hospital in Muscat and the Ministry of Health for 2 decades, and since the last 2 years at the Armed Forces Hospital and the Ministry of Defense in Muscat. He is a clinical lecturer at the Sultan Qaboos University, College of Medicine and Health Sciences, Oman. He is also a postgraduate trainer in pediatrics for the Oman Medical Specialty Board. Dr. Manikoth has published widely in peer-reviewed journals and is a regular contributor to the McMaster online rating of evidence. He has written 2 chapters in Essentials of Neonatal Ventilation. His areas of interest include golden hour for extreme premature infants, infection control, infant feeding, and non-invasive ventilation. Over to you, Dr. Manoj Malviya, for further.
Thank you very much for that kind introduction. Let me share my view. Okay, is my voice okay? Hello?
Yes, your voice is perfect.
Okay.
Please enable a video also. You should be seen also.
Okay. Is that okay now?
Yeah, now it's fine.
Okay, greeting from Muscat. Namaskaram. Salam alaikum. Salam alaikum and hello to everyone. Sorry, I'm just because I had to change my computer. So appreciation, I think in current negativity of COVID-19, I see 2 most positive thing happening is, one is Kerala NNF webinar. I think that is very refreshing. Every monthly, I'm just looking forward to it. So thank you very much. I also would like to thank Manoj and his team for giving me this wonderful opportunity to share my thought on this very controversial topic. And also I want to congratulate him for doing an excellent work for nursing teaching. Second silver lining I see in this negativity surrounding COVID-19 is it that we all has become human. I think we have understood that we need each other. No one is safe until everyone is safe. I think my disclaimer, I'm not a legend. I think we are going to talk today on PDA evidence-based evaluation. We will be presenting the best current available evidence. I don't know how long this evidence will remain valid. The half-life is not known. So I think everybody is advised to exercise their wisdom. I think if you see in neonatology, 10 year is a general half-life. Okay, is there okay? Yeah. The advance in neonatal science has, in last 50 years, not only improved the physiological, but provided huge epidemiological benefit to the society. But I think we have reached a very stagnation point. There is a threatened sense of complacency. That means self-righteousness, means feeling that we know what we are doing. I think as far as PDA is concerned, there are two big bandwagon. PDA self-righteousness is I don't treat any PDA. On the other hand, somebody will say I proactively look for it. And that creates two major issues. One is a authoritative bias. It creates a self-deceptive behavior. I know what I'm doing. And second is more concerning is confirmation bias. I think confirmation bias means a tendency to give more weight to the evidence that confirms your belief and ignore evidence that challenges them. Let me give you an example. Suppose you want to test an hypothesis that in a lake all swans are white. Then what you should do? You should start looking for a black one rather than just finding more white one. That is what is happening nowadays. Okay. 1 minute, just a little bit screen is okay. I think the evidence that would falsify the scientists, what scientists are doing, the evidence that falsify their belief, that will be discarded as an aberration. I think to treat or not to treat is not a new question. It's more than 100-year-old debate. Let me tell you a very interesting story. Okay, Dr. Munro he was a pediatric surgeon. He did first PDA ligation, and then he wrote to the pediatrician in this journal that it is possible to ligate ductors and has many health advantages. Please do not dismiss this idea hastily. And in response to this, pediatrician said that it is possible to do many things that are useless and some things are harmful. So I think the debate is still continuing. So let me begin my talk by asking you first question. The PDA is a big shared uncertainty at bedside. So first question is PDA is considered as an epiphenomena of prematurity, an indicator of immaturity. Is PDA an innocent bystander or pathological perpetrator? I think I will give you 20 seconds and then let's see what you think about this. What are you saying? Relax. I think it's okay. So let's see. So I think almost 50% innocent bystander and all. There is a lot of confusion. Let's see what my talk will suggest. Okay, so for today's talk, I will begin with evolution of PDA treatment, how we started from a very aggressive to reaching now more to a selective approach. I will try to make a business case for the selective approach. Then how to select preterm at risk of complication, defining hemodynamically significant PDA. And then finally, Prakash will cover how to manage prevention and treatment of PDA. So if you see the paradigm of the PDA management has shifted from aggressive treat all to now more reaching towards selective treatment. And I don't know, at the end of my talk, I will put my thought what will happen in next 20 or 30 years. So where we started, I think the first PDA link with RDS was established in 1965. The first successful treatment of PDA with indomethacin was reported in 1976. Fast forward to various physiological, epidemiological, and RCT studies in over next 25 years had shown that PDA was associated with all this morbidity like BPD, IVH, pulmonary hemorrhage, increased ventilatory requirement, and this has resulted it engraved in our mind, soul, and everywhere in our practice and our thinking that left to right shunt is the main cause for all premature complication. I think we overrepresented PDA for all preterm complication, and that has resulted into culture of imperative closure. That means the PDA must be closed. That led to beginning of PDA prophylaxis era. We practice it for almost 10, 20 years till this a very landmark paper was published by Barbara Smith that showed that despite of initial advantages of surgical ligation and IVH prevention with indomethacin, there was no added advantage in terms of long-term benefit and long-term neurodevelopmental outcome. So I think we moved away from prophylaxis treatment. Approximately after 10 years, this landmark paper was published from USA by Dr. Bennett, and he asked to leave PDA alone. He asked for equipoise, and that this was almost involving 56 randomized controlled trial involving more than 5,000 patients. And what it showed is that only for PDA closure and IVH prevention benefit. Otherwise, treatment of PDA is not beneficial to any of this clinically important outcome. So there was some criticism about treatment in control arm. So they adjusted for less than 50% preterm, less than 29 weeks, but the result remained same. Failed to show any improvement in major outcome like BPD, neck, IVH, or cerebral palsy. And this has resulted into adoption of conservative approach. I think before we go to conservative approach, we need to ask two questions. Should we leave all PDA alone? And why was there a lack of improvement in outcome from the trial of PDA treatment? Let's do a little bit of critical appraisal and possible explanation. So I think first it may be possible that PDA may be a modulator of the disease and not true causal relationship exists. Second, a true causal relationship may exist but may not be alterable because of multiple confounding factors present in a very complex NICU environment. And finally, let's see, there were issues with the published study. So if you do a PQ model, population intervention and treatment and outcome, then all these 56 study, there was a wide mix of gestational age. So there was a selection bias. You cannot compare a PDA of 24, 25 weeks with PDA of 32 weeks. They are totally different pathophysiology. There was a significant heterogeneity in defining the hemodynamically significant PDA. So there was a measurement bias. A nice systemic review was published of 67 RCT showed that most of the RCT enrolled patient based only on whether PDA is present or absent. And magnitude of shunt volume was considered in very few trials. And then most concerning is the high rate of treatment in control group. So if you see, these are all patients treated in control group, almost like 38 to 80% of patients in control group received treatment for PDA. So that means that most of this trial were not with treatment and no treatment. It was like early and late treatment. And the more concerning thing is about the other treatment. And it was not well defined and they were not controlled, particularly for fluid restriction and high peak. And they have got a tremendous influence on ductal flow. They are the modulator of duct. And finally, the primary outcome was only ductal closure. The sample size was not enough for other clinically important outcome. So without critical analysis, we moved towards conservative approach. I think those who are protagonists, their rationale for conservative approach are four. I think first is, as we saw, there is the lack of benefit with most of the treatment. Second is the efficacy of medical treatment is not 100%. So then why to treat all patients? And then there is a significant evidence of harm. I think 10 to 30% of patients develop severe, some morbidity or some harm with medical and surgical treatment. And then there is an increased high rate of spontaneous closure. So my next question is about what will be the best approach for 30 weeks preterm infant on day 4 of life with PDA of 1.5 millimeter on CPAP, 5 and FIT of 25%, what you would do? You will treat with paracetamol, treat with ibuprofen, treat with indomethacin, wait for spontaneous closure. What is the best one? You have to select one. I think I will give you another 15 seconds and then we'll see. Okay. Okay, what is the result? I think very good. I think the people's understanding has improved. I think more mature baby. Let's see what is the literature is saying. So I think if you see this graph, the preterm infant more than 29 weeks, they will close their PDA spontaneously by 10 days in 70 to 80%. Whereas preterm infant less than 25 weeks, 80% will remain open. I think preterm infant with birth weight of more than 1000 gram, 94% will close their PDA before discharge. However, there is a concern about smaller baby. I don't know, this smaller baby has to bear the magnitude of shunt for almost 82 days to 100, more than 100 days. Is it normal? We need to ask this question. There are no good predictor of which patient will go for a spontaneous closure. Needs a lot of research on that. So let's see what is the experience with conservative approach. So those who are following, is it right thing to do? So conservative approach is not well defined. There is a variability in interpretation and application. Last year we got one neonatologist from Canada, and then he said he has not performed a single echo in 1 year. So a lot of people just ignore its existence. Many will follow fluid restrictions, will provide rescue therapy if their ventilatory requirement is not coming down. But what is the evidence? There are no RCT comparing conservative versus no treatment. Recently, two Korean trial has been published. I think Prakash will go in detail. And most of it is our population based comparing different eras. So this is a large population-based trial from 280 NICU from USA, comparing from era from 2006 to 2015, from 2006 to 2015, what it shows. So as you can see, sorry about the numbers looking very small. I think as you can see, the treatment of PDA came down from 40 to almost 50% less, 20%. The ligation rate also came down from 20 to less than 10%. And when you see the major morbidity, mortality came down. So whether this mortality improved because from 2016, a lot of neonatology practices have been changed, particularly like CPAP was introduced, better nutrition, better infection control. But in a smaller baby, the concerning is that rate of BPD has increased. Similar data from the same larger database, same result, less use of COX inhibitor, but increase in BPD rate. So sometimes lesson one from what we have learned so far, sometime in life, we might have to take a path which is very complex, but might be right. I think we have misinterpreted in evidence with a lot of confirmation bias. And I like this Nick Evans. We have no evidence of benefit, but more concerning is no evidence of lack of harm. And I think prophylaxis, I think nobody will follow. It is not giving chance to spontaneous closure. Conservative manage, I think, is good in terms of giving opportunity to bigger babies, but it may be harmful for a small, that approach may be harmful for a extreme preterm infant. And needs further evaluation if the, for a particularly preterm infant less than 26 weeks, whose shunt is remaining open for more than 100 days. And this, this is a nice study which confirmed what I just said, that under treatment and over treatment is harmful, done from INO group from 6 countries, including Canada, Sweden, and all. So how to make a meaningful step forward? I think this is a Japanese doctor who survived, who lived for 105 years. I like his quote that science is a lump, it lumps us all together, but illness is individual. Each person is unique, and diseases are to be considered to their hearts. So what we need is not population medicine. What we need is a personalized precision medicine. And how to do that is most challenging. So how to do selective approach? I think we need to identify preterm at risk of PDA related complication. And believe me, we don't have at this stage no validated prediction model currently exists. So I think we have to integrate 3 major group. One is, first is we need to identify the individual vulnerable pathophysiology. Second is we need to define hemodynamically significant in a much better way by echo, not only considering traditional but also some advanced feature. And finally, the most important thing is what is happening to the effect of this PDA to the end organ, particularly like brain and kidney and intestine. And incorporate this by looking into the various organ perfusion by nurse and take into account the various biomarkers. So let's consider one by one. I will go into the individual pathophysiology causing PDA related complication. So risk factor for PDA. I think before we go into detail of risk factor, we need to understand what are the vasodilatory forces which keeps the PDA open, and what are the forces which acts as a vasoconstrictor and enhance closure of the duct. I think before birth, there are most of these vasodilator are derived from placenta, like prostaglandin, nitric oxide, and everything. After birth, oxygen is a strong vasoconstrictor, and other factors are potassium channel and endothelin 1. And if you look at the list of risk factor, is a big list, but I will just say that these are the important one. If the baby has not received antenatal steroid, there is a high risk of PDA becoming more symptomatic in RDS. If your unit has got a policy of liberal fluid intake, there are high chances of becoming a hemodynamically significant PDA. And most important thing is gestational age. I think I like this paper where it says that we should pay more attention to more immature babies, particularly 23 to 25 weeks. And that is why, because they have got low spontaneous closure rate, a high rate of complication, particularly IVH, BPD, and high treatment failure. More, the treatment efficacy is very limited, 40 to 50%. So if I want to group them, the high risk is less than 25 weeks, moderate risk is 26 to 28 weeks, and low risk is more than 28 weeks. So I will not be more concerned if I have got a baby which is more than 28, 29 weeks, and if he has got a PDA which is hemodynamically significant but not on any support, I'll wait and watch. PDA related complication, I think this is one of the most important part of my talk. What is the biological role of PDA in preterm morbidity? Is it a cause or disease modifier? So if you look at major morbidity of preterm, IVH and pulmonary hemorrhage occurs in first 3 days of life, very rare after 7 days unless there is an infection or coagulation derangement. The NAIC will occur in after first week of life, and chronic lung disease usually more prominent after 2 weeks of life. So if you want to see whether what is the contribution of PDA for IVH and pulmonary hemorrhage, I think there is a circumstantial evidence suggesting that timing of IVH and timing of PDation are similar. The intervention like antenatal steroid indomethacin also decreases IVH, also decreases PDA. And DETECT study by Australian showed that if you treat indomethacin, if you treat PDA with indomethacin, there is a decrease in pulmonary hemorrhage. This study was terminated early because of indomethacin was not available, but there was no difference in IVH incidence. Interestingly, the ibuprofen prophylaxis, it closes PDA, but there is no effect on IVH. So that tell you that there is something, some other major variables, a factor might be controlling IVH. And there are, if you want to see the mechanistic study, they are very limited because it needs continuous monitoring of hemodynamic. So let's see what is the common key mechanism of injury. It is very complex and multifactorial. In a susceptible host with immature germinal matrix and impaired autoregulation, if there is a setting for cerebral ischemia, reperfusion injury, and myocardial arterial vascular decoupling, I want to address this something new concept which is coming up. And to this, unintended consequences of supportive care like high PEEP and CO2 may tilt the balance and causing IVH and pulmonary hemorrhage. So let's see what happens during cerebral hypoperfusion and cerebral reperfusion injury. So after birth, the cord is clamped. So the baby is removed from a low vascular resistance placenta. This will lead to a surge of catecholamine, causing increase in systemic vascular resistance, leading to increase in afterload. The placenta is, if it is cut immediately, most of the smaller baby, there will not be DCC. So the 30 to 50% blood will remain in placenta. So there is a decrease in blood volume. So there is a decrease in preload. These both will lead to systemic hypoperfusion. And this will occur in first few hours of life, and I'll say almost like first 24 hours of life. On the other hand, we also use surfactant, so that decreases pulmonary vascular resistance, increases PDation, leptoration, increases preload, and preductal cardiac output will increase, leading to cerebral hyperperfusion. And other factors like increasing cerebral reperfusion is hypercarbia and acidosis, and ischemic injury by high PEEP and mechanical ventilation. But all this hypothesis or this one has not been studied in neonate extensively. I think we have got a very evidence of all small animal or information about, like if you say decrease hypoperfusion, so SVC flow is low, but not a continuous information. So only two mechanistic studies I have come across, which has been published. So this is about 22 preterm, which was 23 to 27 week. Continuous cardiac monitoring was done with echo and MCV, which was 12 hourly, because this is the drawback. You cannot monitor what is happening with the heart and MCV. And continuous flow of cerebral blood flow was monitored with nurse. This is a surrogate marker of cerebral perfusion. And what was the result? The result was that 5 patients developed IVH, and of this, 4 was grade 4 IVH. And if you see, there was a decrease in cerebral perfusion and increase in cerebral oxygen extraction. And just before this hemorrhage occurs, it improves the reperfusion injury, and then it comes down again. And same thing happened with the oxygen extraction. Before it causes IVH, it comes down. And if you look at the heart, there was a decrease in cardiac output, like a decrease in afterload, and then it just improves before the IVH is occurred. And then myocardial performance index also is lower, although this was not statistically significant. But interestingly, that this is very important, that PDA, there was no difference in between the two groups, between IVH and no IVH. However, there was a significant difference in PCO2. So before extubation, the before IVH, CO2 went up, and then it went up high in all the babies who has developed IVH. So this is like you get a smaller baby, you are very happy, you give surfactant, and then you extubate it. And then next 24, 48 hours, this has happened to a smaller baby, suddenly develops pulmonary hemorrhage and all. So it's very important that we monitor their CO2. Another same study, same result, no association was observed between hemodynamically significant PDA and IVH. So I think what it tells us that IVH may be a multifactorial and PDA may be just a modulator. But in both this mechanistic study, there was no difference whether there is a hemodynamically significant PDA in IVH group or no IVH. I think another interesting thing I want to raise is about endomethacin. I think this study, which was done in 85, it shows that the closure of ductus was not related with incidence of IVH. And they said the endomethacin prevents IVH by stabilizing the cerebral circulation. And this is the same thing Dr. Bennett's found in prophylactic endomethacin trial. So endomethacin, I think it stabilized the cerebral circulation rather than acting on IVH, acting on PDA. And that's also proves with the ibuprofen. It has no effect on cerebral circulation, but it closes PDA. So next is, let's look at what happens to myocardial arterial decoupling and its role. So I just new concept, what is myocardial coupling and decoupling? So I think if you want, if the function of cardiovascular system is to provide adequate cardiac output and arterial pressure, to provide sufficient organ perfusion, and coupling will be to do the same job with minimal oxygen consumption and minimum mechanical energy. So the cardiovascular system is said to be in couple if heart and vascular system are complementing with each other. Like if there is increase in afterload, then stroke volume will increase. If there is an increase in preload, the diastolic filling will increase. So they will be called as a happy couple, cardiovascular and vascular system. But what happens in decoupling, I think here Japanese, they feel the venous origin of the IVH, and they feel that preterm is exposed to various loading conditions, like as we saw already, high afterload, high SVR, increase because of PDA, high preload and all. So that will cause a diastolic dysfunction, and this will cause back pressure, the pulmonary venous congestion, and then pulmonary hemorrhage. There is a ventricular interaction, so left ventricular will fade, right ventricular will fade, and this will lead to IVH. So this will call something like decoupling, and I think that is the concept they are utilizing in their treatment. So let's look at the Japanese perspective and approach. So if you look at why I want to raise, because Japanese has got the lowest incidence of IVH and the mortality. However, they have got higher incidence of ROP and BPD. Um, so the question is what they are doing. Are they doing anything different or unique? So what they do is they perform echo every uh, uh, 6 to 8 hourly for first 2 to 3 days, and most of the in ICU monitor end systolic wall stress velocity. What is that? It is an index of afterload. It can be done on parasternal view, and they also measure mean velocity of circumferential fiber. So I think once the end systolic wall stress goes up, then the contractility will go down. So this is in patient with IVH, it has gone up, and mean circumferential velocity has come down. And if you look at the in neonate, this both has got a very sleep stope relationship as compared to the pediatric population. So what Japanese they do, they use morphine, they use a coronary vasodilator, nitroglycerin, and I don't know why this was not reported in Western literature. They use a lot of hydrocortisone. They use indomethacin PDA, and if you see their grade 3 and grade 4 IVH, the incidence is very remarkably low since last 20 years. Although there will be a lot of argument against that, nobody will give morphine and keep the baby ventilated. But how I see is that what they are doing is they are decreasing the oxygen consumption, and they are maintaining the myocardial coupling. And if you allow me to be a little bit more philosophical, then I think what is life? Life is all about the energy. So needs, I think, particularly now recently when I heard Iowa talk, they're also keeping this smaller baby for a prolonged time ventilated and all, and their IVH and survival is equivalent to the Japanese. So I think it needs a broader discussion. We might not have to ventilate for so long, but at least minimum 1 week of life. So lesson 2, I think PDA may be a modulator of IVH and pH. Indomethacin decreases IVH possibly by stabilizing cerebral circulation. Focusing only on hemodynamically significant PDA may not prevent this serious complication. And I think we need to learn or address, look at other literature or wisdom like Japanese, Korean, and Iowa, and need to consider gestational age, DCC, myocardial energy work balance, and CO2. And we need more mechanistic study. I think only 2 studies are there. Okay, I think we need to prioritize our things. Second morbidity I will consider in short is PDA and its relationship with BPD. As you know, the more the immature baby, the higher incidence of BPD, and reported incidence range from 70 to 20% more in the smaller babies. And if you look at Japanese, and the lowest one is the Swiss. Swiss has got lowest IVH BPD rate, 14%, and the BPD of Japanese is 27%. The question comes whether because they have got higher survival as compared to Swiss, and that's why they have got higher BPD, that needs to be answered. If you go see the BPD, the pathophysiology, this is a double hit. So it is a multifactorial complex disease. The contribution of PDA is very difficult to choose out. But I think what we can say that if the patient has received and not received antenatal steroid and has got a PDA, then you might have to treat that one, or has got also chorioamnitis. How it causes BPD? It increases the hydrostatic pressure. It impairs pulmonary mechanics and increases ventilatory support. The common question is asked is what duration of PDA exposure leads to BPD? A very interesting study by Dr. Clayman. I think his contribution to PDA knowledge is tremendous. I think what he said in 4, it is a retrospective data of more than around 500 patients that BPD risk will increase if PDA exposure is from 17 to 14 days. After 14 days, the odd ratio will increase, but not to that exponentially. So I think this is, we need, if you need to treat, we need to treat before 2 weeks of life. Interestingly, like earlier, as I mentioned, when it studied, there was no effect with PDA treatment on BPD. The two recent RCT has been published where the placebo arm has not received a treatment. That was the placebo arm has not received any treatment. So this is like treatment versus no treatment. That also has no effect. But however, these studies were very small sample size, and it was not designed to examine that question. Similar, but this large study from Korean group showed no effect even if you just manage with fluid restriction. Prakash will go into detail about this study. So I think unless most important thing is in future trial, unless the confounders are controlled, treatment may not show any benefit. So lesson 3, PDA and BPD. I think PDA treatment before 2 weeks of life may have some preventive role. The fluid restriction appears to be protective to both PDA and BPD. Needs more data, particularly for growth and all. The future trial quantification of biological impact of PDA on BPD is challenging. Unless confounders and all control, treatment may not show any benefit. Last part of my talk is, I think I will try to cover both together, echo and its effect, PDA's effect on multi-organ. So I think traditionally we started with definition. We are still struggling after 20 to 30 years, needs a higher version. We started with clinical things, and then we said we added ductal size initially. Then that was not enough, so we said we need to measure shunt volume, and now we examine various staging and scoring system, and more recently we need to look at what is the end organ effect, particularly with nerves. So I think traditional criteria, you need to see the signs of pulmonary overcirculation with systemic hypoperfusion, and the ductal size, particularly flow, it is a growing flow, non-restrictive, left to right, and then you need to look at clinical signs with if baby is ventilatory dependent, and then he has got increase in LA ratio or volume overload by LA ratio or pressure load by IVRT or presence of EA ratio in mitral valve. The most important thing is the one neglected aspect of it, echo is studied is the heart. I think we need to learn more what is the effect on heart, particularly cardiac function and coronary function. So I think advanced echo features, although I am not expert on that, but particularly tissue Doppler imaging and myocardial deforming imaging might be helpful, because in one go you can see the systolic and diastolic function. Other things we need to incorporate in our definitions is an organ defect, particularly nerves, and ultrasound flow velocity, particularly of the cerebral vessels. I like this interesting paper publishing. They examine with nerves, EEG, and middle cerebral vessels, middle cerebral velocity. So this was a 27-week preterm infant who has developed hemodynamically significant PDA. As you can see, the initial saturation, coronary saturation was 60 and renal was 72, and nice sleep-wake cycle. But then when we developed PDA, the saturation dropped to 51 and renal dropped to 43, and the sleep-wake cycle disappeared. And they treated with ibuprofen, and there was the saturation came back to 64, and the sleep-wake cycle also resumed. The same thing you can look at various indices in cerebral circulation, particularly the resistance index and perfusion index by measuring systolic and diastolic velocity. I think, but these are all the surrogate marker, and maybe their sensitivity and specificity is less because of auto regulation. And last, biomarkers, they are useful because they indicates volume and pressure overload. However, they are not very sensitive and specific. They are all over the place. If you see this in large PDA, it may be from 33 to more than 4,000. So but however, I must say most of these studies are small, needs a large study, large data. Okay, last is echo limitation. I think we have to, when you do echo, we need to, because there is an issue with reliability, repeatability, and reproducibility. Reliability means closer to the truth. I think if you like a PDA size, if you measure in a color Doppler and if your gain is not adjusted, it might if you might increase the size of PDA. Repeatability means same result in the same setting, like if somebody changes the PEEP and all, the size and the flow might change. The fluid restriction and the fluid volume will have effect on PDA. So there are issues with all these things because of equipment error, measurement error, and location error. Last two slides about can we early echo predicts need for treatment and outcome. I think this is a study by Pereira which looked at ductal size and gestational age, and according to them gestational age is better predictor than size and type of flow in PDA. And about the predicting the outcome, this is a nice study by Hafif Hufas. His contribution along with I think Patrick and our Yasser is tremendous. I think he did one retrospective and another RCT, taking into account he has used this PDA score to predict the BPD. In retrospective score, the predictability was 92%, but the same score when applied in RCT, the predictability dropped to 57%. So I think it also teaches us that we should not rely too much on retrospective data that might mislead us because there is a selection bias. But this scoring is a very promising scoring. It has involved one of the tissue Doppler aspect, looking at the A wave, a diastolic function. So final thought about selective approach, that PDA's biological effect in various preterm morbidity are not clearly defined. We need to have better understanding of PDA contribution to morbidities. We need to learn from other literature, Japanese and Korean. Current echo criteria's ability is limited, needs better echo scoring system. Even if we identify the risks and echo criteria, but that is not assuring us a responsiveness to treatment and better outcomes. So need better risk profile and medication. The best predictor model for selective is urgently required. And who can help us for that? Because there is so much uncertainty, multiple cognitive active biases are there, and confusing evidence. I think my son is going to do AI. I think AI may be answer when there is a lot of uncertainty, randomness, and fuzziness. Multiple data point and with the artificial intelligence and machine learning will able to provide a best probable model and pattern recognition. I think in future, I think AI-based pest production model will be there, and that will be the reality. I think thank you very much. I think Word has much to offer from Oman. I think one should read this article. Muscat is a beautiful place. Thank you for your attention. I think Prakash is joining.
Okay.
Prakash will be joining now. This one is not the moderator.
What happened to your window? 1 second. This is how do you get out of this?
No, you close mine.
Huh?
Where is you? You are this one, and then you share screen.
No, share screen. My is not coming. Can I stop video?
You open. You need to open. You are not open. No?
Okay, okay.
Yeah.
Probably your video is still there. Start video.
Yes. Yeah. Yes.
How did you start the video? Show the video?
Show the video. You are coming.
Where is it? No, no, just a second.
It is there. It is there now already.
Wait, no, my video.
Yes, we can see your video.
Okay, okay, fine.
Here.
Okay, sorry for this software problems. Thank you, Dr. Manoj, for that brilliant presentation and setting the space for me to continue the dialogue on PDA. A very warm good evening to all of you. This is Dr. Prakash Manikoth, consultant neonatologist at the Armed Forces Hospital in Muscat. My topic tonight is prevention and management of PDA in preterm infants. A warm welcome to all of you from Oman, the jewel of the Arabian Gulf. Let me I compliment and congratulate NNF Kerala and IAP Thrissur under the leadership of Dr. Manoj for organizing this ambitious academic activity of IAP Neonatology chapter. I thank them for giving me the privilege and honor to speak here. Disclosures, I am not a legend of neonatology, but one amongst you who continue to learn from the legends, my teachers, colleagues, and the infants we care. I have managed PDA in preterm infants over the past 3 decades, but never practiced early, aggressive, and universal closure of PDA. I have no conflict of interest and nothing to disclose. The story of the blind man and an elephant originated in India and has been used worldwide to illustrate a range of truths and fallacies. I cannot think of a better comparison than this parable whenever we discuss the management of PDA in the preterm infant. Each of us lives in our own world with our own life experiences, and this often leads us to bias characterized by lack of objectivity, confirmation bias, and unwillingness to consider the points of view of others. My presentation will attempt to review the recent evidence for treatment of PDA, discuss methods for prevention of preterm PDA, and finally suggest an approach for the management based on 30% evidence, 30% experience, and 40% expert opinion. Galen, the Greek physician and anatomist, first described in the 2nd century AD the foramen ovale and its valve, and the ductus arteriosus and its postnatal closure. So can I just start this first poll? Does closing a hemodynamically significant PDA make a difference in the morbidity and mortality in premature infants under 28 weeks? Option A is yes. Option B is no. I'm sure this takes less than 10 seconds, being a very simple question. Manage questions are there. Questions written on the notebook. Yeah, okay. I think 85% said yes and 15% said no. Okay. When the same question was given to 100 neonatologists in US and 100 cardiologists in US, they gave the following answer. 90% of the cardiologists were confident that the PDA should be closed, whereas the neonatologists were equally divided. I think this group contains perhaps more of cardiologists than neonatologists. Presence of a PDA is associated with IVH, pulmonary hemorrhage, heart failure, hypotension, decreased systemic flow, neck, and many other things like hypotension, neck, BPD, which Manoj has beautifully explained. And in this video, whenever the cat touches the motorcycle, it crashes. And association of PDA with these morbidities do not prove its causation. In reality, prematurity causes all the following morbidities as listed on the right side. It also results in a PDA in infants weighing less than 1,000 grams. Is there correlation or causation or confusion regarding the relationship between PDA and associated morbidity? The treatment history, according to traditional concepts, PDA is a fetal shunt and it is supposed to close after birth. If it doesn't close, we need to close it. The PDA shunt may be conceptualized as a continuum between a physiological life-sustaining shunt or a conduit, a neutral bystander, and a pathological entity in some micropremise. Hence, it is not logical to ask the binary question whether to treat or not to treat all preterm PDAs. A better way is to ask, should we close every baby's PDA? Should we ignore the PDA in every baby? Which baby would benefit from closing the PDA? When should you treat the PDA? And what strategy is the most appropriate? The above tables provide a snapshot of both the timeline and historical approach to PDA. Surgical ligation was practiced in the 1940s after failure of treatment with diuretics and digoxin. Pharmacological closure with indomethacin started in 1975. 2 decades later, ibuprofen, and another 2 decades later, paracetamol. Reinforcing what Dr. Manoj said earlier, the approach to management transitioned through 4 phases, namely aggressive from 1970 to 2010, conservative from 2010, and selective from 2020, and the future is likely to be personalized medicine. Ever since the first report of spontaneous closure of the PDA by Powell in 1963, reported in the Medical Journal of Australia, controversy continues regarding its optimal management. The above graph shows the variation in the use of NSAID from 25 NICUs in the US relating to 12,000 infants under 28 weeks. As shown by the red line, the annual percentage of infants treated with NSAID dropped from 40.6% in 2005 to 24.1% in 2013. Professor William Bennett, who coined the phrase, "Hey doctor, leave my PDA alone," made immense contribution in the research field of preterm PDA. His watershed meta-analysis in 2010 challenged the prevailing hypothesis that closing the PDA will eliminate the morbidity associated with it. However, his publication has been criticized for including many heterogeneous studies, older publications, and bigger babies. In this particular forest plot, updated in 2020 in the recent symposium, he has included 58 RCTs for PDA treatment or prophylaxis involving 6,029 subjects, and irrespective of the agent used, indication for treatment, route of administration per oral or IV, age at treatment, use of rescue, year of trial or gestational age, effective PDA closure occurred, but no change in associated morbidity. The lack of effect is probably not due to lack of certainty. In Japan and Canada, they have different approaches to PDA management. This retrospective analysis of very low birth weight infants compared the proactive functional echo-guided PDA management strategy of Japan with the selective conventional echo-guided practice of Canada. The lower composite mortality or morbidity outcome in Japan versus Canada only among infants with PDA suggests differential PDA management may have contributed to the variation in outcomes. Japan has the lowest neonatal mortality, also decreased IVH, NEC, late onset sepsis in extremely preterm infants, as shown by this red graph and line in the graph. But unfortunately, and they do active resuscitation from 22 weeks onwards. But Japan also tops the world in terms of ROP and BPD. And how do they manage in Japan? They are managed in a very specialized way. I think part of it Dr. Manoj has already spoken. In circulatory management, cardiac function, volume, PDA status, peripheral organ circulation, and pulmonary arterial hypertension are assessed very early and frequently. And if you look at this middle chart, the cardiac dysfunction without fluid load overload is managed with dobutamine and hydrocortisone. Cardiac dysfunction with excessive fluid load is corrected with volume expanders. Cardiac dysfunction with fluid overload is treated with diuretics, sedation, and vasodilators like milrinone and nitroglycerin. Hypovolemia is treated with volume expanders, and hemodynamically significant PD is closed with indomethacin or ibuprofen. Pulmonary hypertension is treated with inhaled nitric oxide and sedation by morphine. They have very invasive respiratory management with intubation and prolonged mechanical ventilation for more than a month. Nutritional management with early enteral feeding with breast milk, probiotics, and routine glycerin enema. Neurological management by minimal handling, sedation of ventilated infants, and serial brain ultrasound scan. And finally, infection control by serial monitoring of CRP. In very preterm infants, is a non-interventional approach non-inferior to oral ibuprofen or HSPDA for HSPDA more than 1.5 millimeter who are on assisted respiratory support and diagnosed between posterior days 6 to 14 in Korea. The graph on the left represents the total population. The one in the middle represents gestational age of 23 to 26 weeks, and one on the right 27 to 30 weeks. This study found that the non-intervention approach was non-inferior to oral ibuprofen treatment in reducing BPD or death. In the second week of life, what is happening is oral ibuprofen with a lower dose has low therapeutic efficacy for PDA closure. What is the natural history of spontaneous closure of the PDA? D. Clark et al. Conducted a systematic review of 99 studies published between 1990 and 2018 in patients with spontaneous closure of the PDA. He identified 4 groups based on gestational age and birth weight, less than 37 weeks, less than 32, 30, 28, and ductal closure was observed on day 4 and day 8. He found that the spontaneous closure rates were lowest in 28 weeks, below 28, and they had 34% on day 4 and 41% on day 7. The probability of spontaneous ductal closure increases until 1 week after birth, and this favors delayed treatment if you want to treat. This table from Avery outlines the gestational age-specific rates of spontaneous closure on day 4, day 7, and at discharge. 78% of 27 to 26 weeks and 54% of 24 to 25 weeks have their ducts closed at the time of discharge. Now I will come to the second part of my talk, which is prevention of hemodynamically significant PDA. And this is very important because it is better than treatment. Perinatal practices for prevention include prevention of preterm labor, antenatal corticosteroids, delayed cord clamping, avoidance of mechanical ventilation, use of gentle ventilation strategies, NCPAP, ensure intubation, surfactant, and extubation, in rexure, intubation, recruitment, surfactant, and extubation, avoidance of fluid boluses and excessive fluids in very low birth weight infants in the first few days of life, avoiding vasodilatory medications. Prevention of preterm labor involves tocolytics to slow down labor, antenatal corticosteroids once preterm labor is established, and antibiotics for women with suspected preterm pre-labor rupture of membranes. Kleiman observed in 1981 that antenatal administration of corticosteroids significantly reduced the incidence of RDS, IVH, and PDA. There is a wide variation in steroid prophylaxis worldwide, and postnatal steroids also reduce the incidence of PDA if given along with COX inhibitors, but it is not advised due to its harmful side effects. Delayed cord clamping saves the lives of 30% preterm infants by reducing IVH, BPD, and NEC, but only a minority of eligible infants receive it. This quality improvement program of delayed cord clamping over two time periods in Canada in 2013 and 2014 in preterm infants less than 34 weeks gestation at Cleveland, not Canada, resulted in lower need for resuscitation at birth, medical treatment for PDA, and RBC transfusion. Administration of fluid boluses is a common practice in many NICUs. In a retrospective cohort study, very low birth weight infants under 34 weeks gestation who received at least one bolus of fluid in the first 48 hours of life had a higher prevalence of PDA and IVH. What about the fluid intake? The amount of fluid intake on days 1, 2, 3, and week 1 of life increased the risk of PDA and BPD in extremely low birth weight infants. On day 1, only 2% of infants in the 2% of infants in the low fluid group developed PDA, whereas in the high fluid, 25% developed PDA. Fluid intake from 2 to 4 weeks of life was not significantly associated with high rates of BPD or PDA. In this retrospective study of 178 infants 23 to 26 weeks over 2 time periods in Korea, the period 1 when mandatory PDA closure with indomethacin on day 7 without fluid restriction, and in this the average age of ductal closure was on day 13. During period 2, which was a non-intervention involving judicious fluid restriction and diuretics as required without medications to close the duct closed by an average of 44 days. Despite increased PDA exposure during period 2, non-intervention had reduced BPD and was not associated with increased mortality or comorbidities like NEC or IVH. It is interesting to note that lower fluid intake rates of around equal to or less than 107 ml per kg per day in the first week of life were achieved without decrease in caloric intake and electrolyte or renal disturbances. Strategies for fluid management in very low birth weight include fluid intake must be less than or match the urine output. You must allow a weight loss of 1 to 2% body weight per day in the first 5 days. Keep incubator humidity of 80 to 90% to reduce water loss. maintain serum sodium less than 150 milliequivalents, and a total fluid of 60 to 100 ml per kg per day in the first 5 days of life. Add sodium 1 to 2 milliequivalents when serum sodium is 135 milliequivalents per liter and there is weight loss, and maintain a urine output of at least 1 to 3 ml per kg per hour. The latest Cochrane review also established that fluid restriction significantly reduces the risk of PDA, IVH, NEC, BPD, but also it leads to increased postnatal weight loss. For PDA, the relative risk was 0.52 and the number needed to treat to prevent one case of PDA was 7. However, the exact amount of fluid intake and duration is still not determined by evidence-based research. Commonly used drugs in the NICU have the potential to induce relaxation of PDA, and these include analgesics and sedatives like morphine, antimicrobials like gentamicin, cardiovascular drugs like sildenafil, nitric oxide, respiratory caffeine, others like furosemide. Even placement of a UAC near the ductus arteriosus causes exposure with heparin and keep the PDA open. Now I will come to the third part, which is the management of the PDA. There has been a paradigm shift in treatment from early and aggressive closure of PDA to a more conservative approach of watchful waiting for spontaneous closure. Management of PDA can be considered under three broad categories of asymptomatic, symptomatic, and personalized treatment, and each category when and how to treat. The different time points at which in treatment for PDA may be given are listed on the vertical y-axis and include prophylaxis, early targeted treatment, pre-symptomatic, early symptomatic, and late symptomatic, very late, and no treatment. The consequence of treatment or non-treatment are listed on the horizontal x-axis on the top row and include PDA closure, IVH, pulmonary hemorrhage, neck ligation, mortality. Earlier treatment leads to more short-term beneficial effects at the cost of more infants receiving unnecessary treatment. When and how to treat an asymptomatic PDA, prophylactic treatment gives medications to all infants with a predefined gestational age within 24 hours. It is not recommended due to the high rate of spontaneous closure and the side effects of treatment. Indomethacin reduces the incidence of symptomatic PDA, severe IVH, and need for ligation, but it has no effect on mortality or neurodevelopmental impairment at 18 to 36 months. Pre-symptomatic is given in the first 3 to 5 days of life and no beneficial effects with indomethacin on comorbidity. When to treat and how to treat a symptomatic PDA. Start treatment only when clinical signs and symptoms of PDA develop. And this is the approach commonly adopted worldwide. And there are 4 ways to treat asymptomatic PDA. The first one is the conservative or expectant management. The second is pharmacological treatment with drugs. Third is transcatheter percutaneous device closure. And the last is surgical ligation, which can be early and selective. Finally, personalized precision medicine. Personalized medicine wherein the individual characteristics of the patient, which takes into account the genetics, the physiology, pathophysiology, biochemistry, clinical variables. These are taken into consideration when deciding the management. And this is ideally suited for many of the neonatal hemodynamic treatment dilemmas, including PDA management. It involves precision diagnosis and precision treatment and focuses only on those infants most likely to benefit, thereby reducing the side effects and costs associated with unnecessary and potentially harmful over-treatment. The current healthcare model is reactive for prevention and provides standard treatment for the average patient. Precision medicine is an emerging approach for prevention and treatment of diseases and takes into account the individual variability of genes, environment, and exposure. It gives customized care, provides the right treatment, and results in improved outcome with reduced side effects. The future will tell us whether it is hope or hype. So how do you treat a symptomatic PDA? By conservative management. Conservative or expectant management with watchful waiting is gaining interest despite lack of high quality evidence to support it. It is based on the justification that PDA is an innocent physiological bystander. There is no proven causal relationship for PDA with morbidity, and spontaneous closure occurs by natural PDA modeling and flow modulation. The side effects of pharmacological and surgical treatment. It doesn't mean you are totally ignoring the PDA. You need to have continuing active assessment management. The strategies for conservative management of fluid restriction are to restrict fluids to less than 130 ml per kg per day, diuretics to reduce pulmonary edema and left heart volume overloading, non-invasive respiratory support, modulation of transductal flow by increasing PVR. You can adopt measures like increasing the PEEP from 5 to 8, decreasing the I time to 0.35 seconds, permissive hypercapnia, keeping the CO2 around 45 to 55, oxygenation is with SpO2 of 90 to 95, and keep a high hematocrit around 35 to 40, which will increase the PVR and decrease the PDA flow. Let me share the local data of premature infants 24 to 38 weeks born at the Royal Hospital, Muscat for a period of 5 years from 2006 to 2010 with 6,000 deliveries per year. This was a period when we did not practice golden hour. We never had functional echo. We just had conservative management. The group 1 includes 160 infants of 24 to 28 weeks gestational age, and 1/3 was diagnosed to have PDA clinically and by echo during the hospital stay. The group 2 includes 401 patients of 29 to 32 weeks, and only 5% was diagnosed to have a hemodynamically significant PDA by same clinical and echo during that period of hospital stay. In group 1 with 52 PDAs, 23 received conservative management and 28 received pharmacological closure. Only 3 patients in the whole country during the 5 years underwent surgical closure, and this is the only center where we are closing the PDA, and 1 was inborn and only 2, and the other 2 are outborn. It is always wise to listen to William Silverman, the father of neonatal intensive care, whenever we discuss about pharmacological treatment. We cannot always make our patients better, but we can always make them worse, quote unquote. Pharmacological agents useful for PDA, symptomatic PDA, can be grouped under 2 groups. Agents for treatment of heart failure like diuretics like furosemide. This will reduce the pulmonary edema and fluid overload. And secondly, agents that induce PDA closure like indomethacin, ibuprofen, and paracetamol. 3 RCTs found no benefit of furosemide for symptomatic PDAs. Increased renal synthesis of PGE2 by furosemide may contribute paradoxically to ductal patency. And the side effects of furosemide are well known: acid-base disturbances, electrolyte, nephrocalcinosis, even 10 milligram total dose can cause it, and sensory neural hearing loss. What is the mechanism of action of drugs used for PDA closure? All medications ultimately result in a decrease in PGE2, PGI2, and thromboxane on the right side. And both indomethacin and ibuprofen are non-selective COX inhibitors that work through inhibition of the production of prostaglandins from free arachidonic acid. Paracetamol acts downstream at the POX site, that is the peroxidase site, and prevents conversion of PGGT to PGH2. Which pharmacological agent and through what route has the highest likelihood of PDA closure? This is a very busy slide, and in this busy slide, each column represents a treatment modality of using any medication by any route or no treatment. Each row on the y-axis represents an outcome like PDA closure, mortality, IVH, NEC, or BPD. And each box is colored red to green, red indicating 0 and green indicating 1, which means the green one is always the best. So in this network meta-analysis of 68 randomized controlled trials involving 4,802 infants, high dose per oral ibuprofen has the highest close of closure of PDA, and placebo or no treatment, that's on the right extreme, does not increase morbidity and mortality, and standard dose paracetamol The third one on the top with 0.82 is also equally effective. The plain language summary of this 94-page article, including supplemental content. If you want to close the duct, use high-dose oral ibuprofen. It doesn't hurt the baby if you don't close it also. Let us take the three drugs, spend a couple of slides for each one of them. Prophylactic indomethacin is given in the first 12 hours to all neonates to reduce IVs, pulmonary hemorrhage, and excess PDA. It is not advised in routine settings, but may be considered in certain subgroups like lack of antenatal steroids, male sex under 26 weeks, and in certain units where there is a high baseline rate of IVH, wherein the benefits may slightly outweigh the risks. It is sensible to reduce IVH by implementation of a neuroprotection care bundle than to rely on prophylactic indomethacin irrespective of PDA. The dose is less, you give 3 doses over 20 to 30 minutes, 24 hours apart. Less than 48 hours, the dose is 0.2 milligram on day 1 and 0.1 milligram on day 2 and day 3. More than 48 hours, the dose is the same for 3 days. The side effects include alterations in cerebral, renal, and splanchnic blood flow, rise in urea and creatinine levels, and renal failure, spontaneous intestinal perforation neck, and impaired platelet aggregation. The second medicine is ibuprofen. It can be given orally or intravenously. The peak levels are reached earlier if you give IV, but the elimination is slower after enteral administration. It's available as 3 preparations: ibuprofen, lysine, sodium, and arginine. This is the intravenous. The dose and frequency, low dose is 10-5-5 for 3 days, and the high dose from day 4 onwards, 20-10-10 per kg per dose for 3 days. It doesn't alter cerebral circulation. It's metabolized in liver and excreted in urine. So hepatic or renal impairment can lead to adverse reactions. But if you co-administer vancomycin, you have to reduce the maintenance dose by 20%. If gentamicin is co-administered, you need to extend the dosing interval of gentamicin by 12 hours. Both oral route and continuous infusion have got higher closure rates. PDA closure after the first course is 70%, and after the second one is 50%. And side effects include GAT bleeding, spontaneous intestinal perforation, raised serum bilirubin requiring phototherapy. Now, the third drug is paracetamol. It is the most commonly used over-the-counter drug, and it is very commonly used during pregnancy. It is a new rock star in neonatology. It's good, it's cheap, it's effective. It's morphine sparing and PDA dosing. The dose of paracetamol it can be given as IV, per oral, or per rectal for 3 to 7 days with 48-hourly monitoring of liver function. The dose above 28 weeks corrected gestation is about 15 milligram per kg per dose, 6th hourly, and for below 28 weeks, you have a same dose as a loading and a maintenance dose of 7.5 milligram per kilogram 6th hourly. The dose of 15 milligram per kilogram 6th hourly provides a serum concentration of 15 milligram per deciliter, and that's all which is required to induce ductal closure. This graph on the right side, you don't need more than 20 to close the duct. The antidote of choice for overdose is N-acetylcysteine. The side effects, hepatotoxicity. If you give IV, you may have hypotension, and there is a long-term concern about neurodevelopmental sequelae like autistic spectrum disorder or attention deficit hyperactivity disorder. Cochrane review in 2020 provides moderate quality evidence that paracetamol is safer than and as effective as ibuprofen or indomethacin in closing a PDA with fewer side effects. The risks associated with drug therapy and surgical ligation have led to discovery of alternative strategies for PDA closure. Transcatheter device percutaneous closure of the PDA has become a game changer in recent years and a safe and reliable alternative to surgical ligation. It's a minimally invasive procedure with high success rates and few procedure-related complications and absent post-ligation syndrome. The earliest PDA occlusion was performed in a low birth weight infant in 2001. In 2019, FDA approved the Emplatzer Piccolo occluder for premature infants more than 700 grams to treat HSPDA. Dr. Sadanandam Shyam presented his retrospective review of 100 percutaneous PDA closure in infants in under 1000 grams. The mean age of the procedure was 24.3 days and the mean weight was 821 grams. The procedure success rate was 100% with major and minor adverse events of 3% each. It is feasible to perform a transcatheter PDA closure in infants less than 1000 grams safely, but it is more important to decide whether you need to close it. Surgical closure is sought when HSPD is refractory to two courses of medical therapy in the first few weeks of life, or when there is contraindication for medical therapy and coil or device closure is not feasible or possible in your place. And duct-dependent CHD is an absolute contraindication. The risks of surgical procedure include bleeding, rupture of lymphatics and chylous effusion, injury to recurrent laryngeal nerve, residual ductus, ligation of the descending aorta or LPA. It carries an operative mortality of 3%. It can result in severe ROP, BPD, neurodevelopmental impairment in childhood. If you are on duty, how do you approach an acutely unstable postoperative patient after ligation? The differential diagnosis should include post-ligation cardiac syndrome, which occurs in about 4 to 12 hours postoperatively, as manifested by oxygenation and ventilation failure and systemic hypotension. It is very common in preterm infants and related to increased left ventricular afterload and response to intravenous dobutamine or milrinone. The second differential is a non-specific inflammatory response. Surgical complications can cause it, adrenal insufficiency where you have to give hydrocortisone, and finally don't forget sepsis. Before completing my talk, let me suggest two clinical pathways for PD assessment and management. This is for a preterm infants 27 to 30 weeks. Conservative management is advised in the first week of life, since spontaneous closure occurs in about 35%. If the hemodynamically significant PDA persists, early treatment with either paracetamol or high dose ibuprofen is advised. If HSPDA persists for more than 4 to 6 weeks, after you may consider second course also before that. So, but if it continues for more than 4 to 6 weeks, I'll just clarify. After the first course, you can have a rescue treatment if the first course doesn't close. And after the second course also, if it doesn't close and it stays for more than 4 to 6 weeks, the patient is on ventilator support. You have no other option other than going for a transcatheter device closure or surgical ligation. The second pathway is for preterm infants 26 weeks and below. You need to consider certain clinical features before looking at them. What about lack of antenatal steroids, maternal infection, chorioamnitis, preeclampsia, APH, male infant, asphyxia, growth restriction, severe RDS, baby has high ventilation requirement. These infants, you perform targeted echocardiography at 18 to 36 hours after birth to screen for the presence of and the hemodynamic significance of any PDA and classify them into one of the three groups. The first group is the green color on this chart. It's either a small PDA or a PDA with a low volume shunt. You observe and repeat the TN echo as clinically indicated. If the low volume shunt is due to high pulmonary vascular resistance, you follow echo every 1 to 2 days until the PVR normalizes, or you have to start treating with INO for hypoxic respiratory failure. The second group is due to cardiac dysfunction of either the left ventricle or the right ventricle. If present, it is treated with dobutamine at 2.5 to 10 mics per kg per minute as first line and alternate agents PRN. And when the cardiac dysfunction is resolved, you may reevaluate through ductal significance and follow the PDA guidelines. The third group is HSPDA. You may include both the echo findings on the right side and the clinical findings, and then you classify them as a moderate to large PDA with shunt volume. And based on the joint decision between the clinical team, you may start treatment with paracetamol, 15 milligram per kg per dose, IV 6 hourly for 12 doses. You reassess after 3 days. Within 12 hours after completing the three days of treatment. If the PDA still remains significant, you may continue paracetamol for another 5, or some people even go for 7 days. So either 20 or 28 total doses, and you need to monitor the liver functions every 48 hours. After these 2 courses, you might try a third rescue treatment with an alternate drug like ibuprofen at a higher dose. And if the patient is still on the ventilator and hemodynamically significant, there is no other option but rather than to consider definitive closure. To quote Donald Rumsfeld, there are known knowns. There are things we know that we know. There are known unknowns. That is to say, there are things that we know we don't know. But there are also unknown unknowns. These are things we don't know. The ideal approach to the management of PDA in preterm infants remains unknown. So let us hope the trials listed here will help us in moving forward. The one on the yellow and the green, they are already finished. The first trial is the EPAR, which is, these 2 trials have been presented at the PAS meeting in June. The early paracetamol, the pilot RCT of early paracetamol to promote closure of PDA in preterm infants and reduce the number of infants requiring intervention for PDA. The intervention group had a higher rate of ductal closure at 5 days, 69% versus 28%, a relative risk reduction of 0.57, and a number needed to treat of 2.4. This study, although pilot was closed 50% because of effective closure, so the study was not did not recruit more numbers because of efficacy. The second study is in France, Trinocapy. Early echography, echo-started treatment of PD with ibuprofen did not change the survival of infants with cerebral palsy at 2 years, but it might reduce the incidence of pulmonary hemorrhage, and this they treated with ibuprofen. The third study, which was again a pilot study by Afif from Ireland, got published in Journal of Pediatrics. So this study used again IV ibuprofen using a very strict criteria, and he used the risk-based severity score. Even newborn infants who received gentamicin were excluded from the study. The overall PDA closure rate after treatment was 57% in the intervention group and 17% in the control group. There was no difference in the primary outcome or clinical outcome of CLD or death, and that was the primary, and so it has not been really effective. The other 2 studies, Benedictus and Baby Oscar. Benedictus is in Europe. It is recruiting infants less than 28 weeks and early treatment with ibuprofen. The Baby Oscar is happening in UK. They are also selecting patients and looking at the incidence of death by 36 weeks, and both the studies are ongoing. To summarize, treatments for preterm PDA do not improve the long-term outcomes. Prophylactic treatment or asymptomatic PDA is not advisable due to the high rate of spontaneous closure and the side effects of therapy. Conservative PDA management combines various clinical strategies to reduce the left-right ductal shunting without pursuing active ductal closure through medical or surgical means. Targeted therapy of PDA screening and management of HSPDA in preterm infants under 26 weeks may be useful to improve the short-term outcomes. A personalized approach based on risk factors, clinical and significance of the PDA may be the route for the future. Questions are always welcome. Answers are not always present. And thank you for your patient listening. With this, I end my presentation.
That was a very wonderful discourse by Dr. Manoj and Dr. Prakash, one of the best lectures we have ever had on this platform. Congratulations for that presentation, sir.
Yeah, thank you so much. It was our pleasure to join you all.
Thank you very much.
Now, see, in our classical Indian setting, many of the units we have We don't have cardiologist support round the clock, and it is usually the neonatologist with some functional echo who would be at the bedside with these babies. At the end of it, I would like to ask Dr. Manoj, if you want to give us 2 or 3 important points during functional echo where a neonatologist would think that would be useful in deciding whether this is a significant, hemodynamically significant PDA for a difficult baby. What?
Nice question, but a bit difficult to answer. I think I'm not the expert, I'm not a cardiologist, but what we are doing in our unit, we have got a very nice team. Is there an echo? Okay, we have got a very nice team who performs echo. I think most of the traditional parameters, evidence of pulmonary overcirculation and systemic hypoperfusion, that particularly pulmonary overcirculation and all may not be present immediately on first day one. So first day we might have to for more neglected aspect is the coronary and cardiac functioning, particularly systolic and diastolic. I think most recent thing is that we have just start doing the advantage is that you will be able to see single systolic and diastolic function together, and you can calculate myocardial performance index by measuring early. I think that's called contraction time and relaxation time divided by injection time. So basically, in short, I can say that what we need to do concentrate on more cardiac function. Otherwise, signs of pulmonary overcirculation and systemic hypoperfusion we usually take into account before deciding for the treatment.
I had a quick question, sorry, which I wanted to ask both of you. If you can just tell me at what point will you get an echo done in a baby? Okay, to both of you. And second one, and after doing that echo, when do you treat? I know we're looking at all the hemodynamically significant echo parameters, but is there a size that tempts you to treat in a symptomatic baby? So the first question is, when do you actually do an echo?
Okay, so I think particularly if you have got a baby who is less than 26 weeks gestation, then we will like to look at the various loading condition, particularly within first 24 hours. Okay, the purpose is here is to prevent IVH. If you have passed that time, then your most important thing you want to prevent is if there is a ventilatory dependency, then BPD. So after usually you like to treat between first to second week of life, particularly the smaller baby. Bigger baby, I will not be too much worried about, particularly 26, 27, 28 week or 29 week. So for an Indian scenario, I worked in Hyderabad for 6 years, and one of the common denominator which I found is the sepsis. Initially PDA is closed and reopens. So I think we need to look into that aspect. I will treat aggressively the infection first and then treat PDA. So first I will do in smaller baby, I will do echo within 24 hours. Like a Japanese, we're going to try. For a bigger baby, if the baby is asymptomatic, I will do echo.
Dr. Prakash, your opinion on this?
Prakash, you can answer on treatment.
Yeah.
I think
you're muted.
Yeah, I unmute. Hello.
Yeah.
If you classify as a hemodynamically significant PDA based on clinical features and not echo alone, that is the time you decide to treat. So when to treat is an important decision people take, and that if you have decided based on whatever Dr. Manoj has said, echo findings by functional, and you have the clinical features you can classify into mild, moderate, severe. And it correlates with the clinical assessment by the treating team. A decision is taken to treat, and this decision is not normally hurried in the first week. So we normally wait for the beginning of the second week to start treatment.
And when would you do your first echo?
No, we don't do echo guided treatment, although there are some units doing that. You have the facilities and luxury of doing it after the first dose of brufen, you might do it, but many centers don't have the luxury of doing it.
And that is the situation with many centers here also. So that's why it's important to, and I'm sure in the audience we have people who can't get the echo easily. So that is why I asked that question. I think we can take a few questions from the chat box now. Dr. Suryanarayan, you want to start? Okay. So the first one was, how does phototherapy become a risk factor for PDA? Any one of you can take that.
You want to answer, Manoj?
Okay, I think phototherapy has been shown to alter the prostaglandin pathway, and there was a small study was done covering the patch of upper patch of the body with the silver foil in order to prevent the incidence of PDA. However, there was no difference in treatment with that patch or no patch. So it alters the prostaglandin pathway.
Okay. The next one is for selective PDA treatment. Would like to know your thoughts on the PDA scoring developed by Dr. L. Kufash in Ireland.
Okay, so I think Hafif has a tremendous contribution to the PDA knowledge. I think he used this scoring system for, first he used in a retrospective study, particularly to predict the BPD. Okay, and in that study, he found to be the prediction rate and sensitivity and specificity and positive predictive value was 92 and 87%. But with the same criteria, he just published last month, the randomized control trial. The prediction rate has dropped. So he has used 5 criteria, particularly gestational age, left cardiac output, PDA size, then I think A prime wave and Pmax velocity. So regarding the treatment, in that study, there was no difference. When if you use this parameter, the incidence of BPD was same as compared to other arm, which was non-intervention. Is other arm didn't receive any treatment. So I think but the treatment arm has got a higher mortality also. So this raises a question that whether this scoring system is perfect. First is it has not detected what it was meant for. And treatment, it was more or less same. But this study was not designed to answer that question. The sample size was very small.
The next one is an important question. Either one of you or both of you can tell us what you do in your units. If a baby is on full enteral feeds, but the PDA is hemodynamically significant, would you restrict the feeds, and then to how much?
I think I can answer that.
Yeah.
You can.
Yeah, I will
Unmute. Dr. Prakash, you have to unmute.
Okay. If the baby is tolerating the feeds, we will first of all, you are planning a conservative management, right? So when we are planning a conservative management, whatever guidelines I mentioned, which is listed in the seminars of neonatology, we restrict the fluids to around 120 to 130. We will never go above that. And with that, if the patient is tolerating feeds, we might make it from say 2 hourly to hourly, and continue with this period of watchful expectancy. You might consider a short course of diuretics. You play with the PDA shunt flow modulation by increasing the P and non-invasive ventilation, and give some time whether it will come down. If you are planning to treat, then it's a different. Somebody might ask you that, should I keep NPO? Should I keep NPO? I don't think you need to keep NPO. Some of us give trophic feeds while you are treating with either of the drugs. or if this patient is already on say 50% feed, I find no reason to stop the feed. I would prefer to continue the same 50%, but I will not increase the volume of feed during the process of treating with medications. This is how I look at it.
I can just add.
Is there any concern? Why do you want to restrict the? Why you don't want to increase the feed?
No, if there is always a risk of there's an echo. There's always a risk of necrotizing enterocolitis if the baby is on full feeds with 160 ml with systemic hypoperfusion, which has been documented by decreased flow in the celiac axis, and you're asking for trouble. So a few days of 2 or 3 days of keeping at status quo is not going to change the issue. So but I wouldn't keep NPO totally, which is totally wrong. Especially you have to see in a baby who is small for gestational age and be selective. But I wouldn't be aggressive and keep going all the way to achieve growth and nutrition at this point of time. So
that's what, yeah, we follow as well. We actually keep the feeds as it is. We don't increase it during that period. That maybe for 2 or 3 days, and then subsequently increase it.
I can add something?
Yes.
I think recently we got a nurse, and the nurse data has shown that the mesenteric perfusion after the treatment with Brufen has improved. So I don't see any reason to restrict the fluid or feed. But particularly in India, if you have got a high population of IUGR, you have to be a little bit more careful.
So now with regards to percutaneous catheterization, any personal experience on it? Transcatheter device closures, okay. With regards to BPD, our usual confusion of after the first week is that the baby is stuck on the mechanical ventilator, and is to whether to go for PDA treatment or steroids first, if there is a clinically and significant PDA. So.
No, we don't have experience of percutaneous device closure. We do it only in bigger babies, around 2 kilos. That 700-gram Amplatzer Piccolo has not yet come here, so I have no experience to share with you. Regarding the confusion of treating the BPD or PDA or with medications, I wouldn't jump to treat with steroids in the early second week. If the assessment by PDA is shown to be hemodynamically significant, I would rather treat the PDA rather than start steroids for BPD at the beginning of the second week. And it also depends on the gestational age of the infant. So it's too early to jump and give prophylaxis or little early treatment with steroids and then get into trouble, because of the reason that the side effects of steroids are more than even if you give DART protocol. I would prefer if you have an hemodynamically significant PD established by echo and clinical radiological combined 360-degree assessment, I would rather go for that rather than focus on the BPD steroids and then closure. No, that's not the way.
Okay, just so the next question is, do you use any lab parameters for those who...
Is this facility available in your place, catheter device?
Not really.
Dr. Preeta.
Yeah, we have it for babies 1.5 kilo and above.
Are you using coils or the same Piccolo?
So we are using the coil is what they're using for the more than 1.5.
Yeah, coils
preferably 2 kilos actually even here.
Yeah,
that is better. Yeah,
we also have coils, but not for below 1 kilo.
Yeah.
Dr. Prakash, I have one doubt regarding the prevention aspect. You said restricting the fluid in the first week to around about 107 ml plus minus. Do you think that has got to have a good beneficial outcome in this PDA not becoming hemodynamically significant?
Yeah, I think my experience for the last 2 decades, I think I showed the data relating to 2006 over a period of 5 years. Our incidence of PDA at that time, it was much less, maybe 1/3. And this is a time when we were not practicing either golden hour or functional echo or delayed cord clamping. And we were much, now we are much ahead of that. So we have come a long way, and our patients are having better hemoglobin. So I'm sure we'll have much better chance. And these studies were done in Korea and Japan, and they found that the nutrition did not suffer. A little less weight gain the first week is not a problem. But remember, we are started TPN right on day one, and we don't. But the volume of fluid, we start with 60 to 70, and go up to 100 in the first week of life, and that makes a big difference in preventing rather than treating the PDA from becoming. PDA will be there, but it will not be hemodynamically significant.
I think, can I add something? I think it's the Korean study is very promising, but needs more data about it. Is it a water restriction or is it sodium restriction? I think particularly that question also needs to be answered.
Yeah, the next question I'll just take up. There are a lot of questions, so we'll try and finish them. Are you using any lab parameters? So do you think any lab parameters for those who don't have an echo easily available, like a BNP, troponin, which would be useful?
So various biomarker has been studied. We are not using any of that, but the results are all over the place because the sample size was very small. So I think biomarkers and NERS, I feel they are very promising, and there is a large study waiting from USA. They have incorporated biomarkers, particularly BNP and pro-BNP, with the sequential echo and waiting for a spontaneous closure to predict which one will close, and waiting for looking for morbidities and long-term outcomes. So that will be interesting study too.
Manjusha has a question that she has a 27-weeker who has got 3 trials of medical closure but failed to close the PDA. BPD has become well established. On mechanical ventilation, cardiologist is not ready to take chances on operating on these high settings. Now what does she do?
Okay, so I think I just question here the disadvantage is you cannot ask counter question. What is the corrected gestational age? Because I think if this baby is small and really stuck on ventilator, then you might have to find some way. Because there was one study done, delayed paracetamol versus surgical closure after 36 weeks of gestational age, corrected 36 weeks of gestational age. The paracetamol will close PDA, but will increase the mortality. So I think he needs to find out a way to, and also look into why this baby has been stuck. Look at your rate of BPD. I think if it is more than 25 to 30% in smaller baby, because if you are catering a larger population and then getting a BPD, then you need to look at what is your ventilation strategy, how you are managing infection, how you are treating the baby with nutrition. That all variables you need to look at.
Yeah, and the other thing is if the PDA ligation can be done
Small
in-house.
correction, that is a question was posted in the YouTube and Dr. Manjusha has just...
Okay, right. Yeah, so just that if it is in-house, I think it will be a little more easier. If you're not moving a child who's so critical, that might be another thing to promote in-house PDA ligation. I think that would be...
I totally agree. The PDA, there was Dr. Patrick Marmota has done a large study on this. The outcome is bad if their babies are outborn and it is transferred for a PDA ligation. When I was at Sick Kid also, that data was very obvious. What we are saying is correct.
Dr. Parsarde has got a question. Which is the best drug to treat PDA? Acetaminophen or ibuprofen or a combination?
Prakash, you want to answer this one?
I think the paracetamol is good. It is cheap. It is effective. So I think all the 3 things: good, cheap, and effective. And that if you see that green and red score, it says that high dose oral ibuprofen is good, but paracetamol is equally effective. And if you want to prevent a second time to close the medicine, it doesn't require with paracetamol. So that 94-page summary of that Sukra analysis, and the best is, of course, if you grade, is oral ibuprofen high dose. But there may be side effects. You have to monitor the platelets, you have to do the CBC. There are many things before you ibuprofen, but for paracetamol, you don't need to. But for a short term, I hardly, and it can be given oral, IV, or even rectal. But rectal, the dose, the absorption is erratic, but it might work. Suppose you have a very sick child, somebody might ask, I don't have IV, what can I do? So I would personally prefer, we have switched over from ibuprofen to paracetamol, but ibuprofen is also. And what about the cost of ibuprofen? I was shocked to hear that a 3-ampule course will cost more than $1 lakh in India. Here we don't bother about the cost here if you're giving IV in a sick child.
Right.
Okay.
So there is a question which says, please explain what you said when you said insure and inrexure.
Insure is actually intubate, give surfactant, and extubate. This is nothing to related to, especially to PDA. Any preterm baby, this is how you give surfactant. When the baby is brought from the labor room, the baby is brought with a nasal positive airway pressure. You initially do a TP resuscitation. Baby is brought and put on CPAP or non-invasive ventilation. If the oxygen requirement goes more than 30% in extreme preterms, that is a recommendation to give surfactant. And surfactant is normally given by a short period of intubation. The surfactant is given and the baby is extubated and put back to non-invasive ventilation, either in the form of continuous positive airway pressure or NIV, whichever you are familiar with.
The question is inrexure. Yeah, the question is regarding inrexure.
There is a period of airway recruitment before giving this surfactant. You want to add, Manoj? Inrexure? You want to add?
No.
Okay. So these are two methods, and now we have methods like LISA, MISA, nebulize. There are many methods for that. So basically, it's a lung recruitment, short period of giving surfactant. This is to basically to treat the PDA rather than treat the RDS rather than the PDA.
Yeah. Now there's a question, a practical question, where is a 28-weeker with delayed cord clamping not done, mechanically ventilated from day 1, surfactant given, showing signs of tachycardia and I suppose other signs of failure they haven't mentioned, but increased mechanical ventilator settings. So at this point, should we close or not? In case we don't have an echo and in case we have an echo, I mean, how do we take that call? If other causes are ruled out, like sepsis, etc.
You want to start? I'll add on.
Yeah. So I think if baby is the only two positive things which you are told, everything is normal and tachycardic. So that baby is not that bad. What is his ventilatory requirement and all? We need to look into that.
It's going up. The mechanical ventilator settings are going up for this baby. So should we close or not is the question.
So if the size is big, that there is evidence of pulmonary overcirculation, sign of, and there is no, it is a left to right shunt, not because on day 1, a lot of shunts are 30% or more than 30% is right to left, then I will be little bit reluctant to close that PDA. If the shunt is purely left to right, significant signs of pulmonary overcirculation, significant systemic hypoperfusion, myocardial dysfunction, EA ratio is high, then I will treat that baby. Particularly smaller baby, 26 weeks.
Right. So,
can I add on to that?
Yeah.
You need to be if you take 10 patients with in that age group, say 26 to 28 with severe RDS, you need to be careful when you require subsequent repeated doses. In the past, we have been giving second dose and third dose of surfactant when the ventilator requirement and oxygen requirement are going higher and higher. Of late, with the functional echo being available and colleagues familiar with doing it, we have found that at least about 10 to 20% of them got significant pulmonary hypertension, and closing the PDA blindly is the worst thing to do. Neither is giving a second and third dose of surfactant going to do better. So you have to wait, either treat with nitric oxide or sometimes sildenafil. Wait for the PDA. It's a fine balance. The right left shunt will become left right. You might need to close later, but not on day 2 as is mentioned. So echo will help you rather than blindly giving either medication to close or surfactant to think that things will get better. Your X-ray might guide you. If it's a bad RDS, the haziness will still continue. But if it's a little lungs are getting cleared, but still the oxygen requirement is high, then it's possible that in the absence of echo, you need to have the clinical sense to guide your management. So no absolute yes or no. That is my take.
Right. A question from Dr. Altaf Ansari. At what stage of feeding will you consider oral ibuprofen? Full enteral feeds or before that, or would you give ranitidine along with it?
Generally, the oral if you have the choice, I would prefer not to give oral feeds, oral medications. We have the luxury of giving intravenous either paracetamol or ibuprofen. But in most of the Southeast Asian developing low and middle income countries where these are not possible, people are diluting it with EBM and giving it intragastrically. But you may have a risk of SIP. That is the price you pay for it. The rectal absorption is, I have tried, but unreliable. It works, but you are not sure whether how much is the dose, and things are little not very clear about it. Whereas intragastric you give, it is more effective.
So what if the baby's NBM at that time? Would you still give it orally?
No, I mean, personally, I would prefer IV. I wouldn't.
No, I mean, we don't receive it. So
no, you don't need to be on full feed to give the medication. Most of the studies have done without reaching even 20% of the feeds. Yeah. Most of the published studies have given either ibuprofen or paracetamol without even reaching 1/3 of the feeds.
And I think definitely I will not use ranitidine because it has been shown to increase infection. Since last 4 or 5 years, we have not used ranitidine at all. So I think instead of PDA, baby might have problem with the infection if you will use ranitidine.
The other thing I tend to do, if you are NPO, I try to give IV indomethacin, which is available here, because we do not have the other ones in IV form. So now, so for restricted fluid infusion, would you recommend starting fluid infusion on day 1 of life of preterm, who is less than 28 weeks? I couldn't get that question, but probably they will clarify later.
No, we need to restrict the fluids because our practice is to give as for a 28-weeker, we start with 60 or 70 ml. I mean, it's because we are using incubators. For open care, you might add little more for the extra insensory loss and transabdominal. But the basic issue of restricting fluids and starter TPN from day first hour of life is mandatory. Then only you will be able to reduce this problem. So
and
in fact,
the important point that you said in the slide, I think needs to be highlighted, where you said that to also look at the urine output to guide you to some extent.
Yeah. All these vital signs, you look at the sodium. We don't routinely blindly write TP and sodium second day, 3 millimole, some textbook figures. No way. You have to individualize care. This algorithmic approach is not going to help overcome this treatment. An individualized care in which you look at the electrolytes, the weight loss, and as you said, the blood gas parameters, lactate, everything is required.
Dr. Prakash,
yeah.
Regarding intravenous and oral paracetamol, your take on that?
No, if the baby is not reached full, because intravenous paracetamol ensures effective blood drug concentration, whereas oral, you are not sure it's effective, especially in a baby who has not reached full feed. The efficacy is proved, and whatever pharmacokinetic studies have been done, they have done with better results with intravenous dosage. And they have found that a 15 milligram per kilogram 6 hourly achieves a concentration of 15 milligram per liter, and that is enough to assure closure. You don't need more than 20. That 20 to 30 is only for pain management.
Yeah. So you mentioned dobutamine in the flow chart. Are you saying that dobutamine is the first choice? If there is PDA, this is Dr. Altaf.
Yeah, dobutamine is always the first choice because there will be always an amount of cardiac dysfunction, and dopamine will increase the systolic blood pressure and give a false sense of normalcy. So dopamine is not generally advised, except when you have a patient who has got a PDA and is in septic shock. Then it's a different game. You have and then both the systolic and the diastolic blood pressures are down. Then you might have an option of using dopamine, but not dobutamine. So universally, people use dobutamine. Dopamine has been widely used throughout the world, and we were also using it many years back. I think now most people have changed the practice. Manoj, you want to add?
Role of milrinone?
I think if only isolated diastolic hypotension is there, you can just wait and watch and use flow modulator like increasing PEEP, decrease fluid and all. Unless until also systolic hypotension occurs, then you need to have some inotropic support like the dobutamine. And
when would you think of milrinone?
hydrocortisone.
Okay. Milrinone, when do you think of using milrinone in this situation?
So milrinone is particularly if you have got some degree of pulmonary hypertension and left ventricular dysfunction, then you can use this. In presence of PDA and to decrease afterload, like Japanese are using isopropanol, the coronary vasodilator. There was one study done on a very small population using milrinone to decrease afterload, but that was not effective. So you need to have your blood pressure to be good, and there is evidence of pulmonary hypertension. Milrinone, there is evidence of pulmonary hypertension with left ventricular dysfunction.
They wanted a summary of Dr. Purushottam wants a summary of the echo criteria for a hemodynamically significant PDA.
So
which are the things you need to look for? Yeah.
So as I said, still we are looking what traditional criteria, particularly for the size, you need to look at if it is more than 1.5 or 1.4 millimeter per kg. The flow should be left to right, growing flow. Then you need to look at the signs of pulmonary hypercirculation, like AE ratio, arterial to aortic ratio, more than 1.5. Then you need to look at various other parameters like left ventricular output, E wave, and all that will be telling you the pressure overload. And then to treat or not treat, one is to look at the diastolic still, particularly all systemic vessels, brain, then abdominal aorta, renal arteries, and all. If that all things are there, but this is not correlating with the outcome. That is the thing. We need more information than what we are doing, particularly how the heart is coping and how the other organs are really adapting by looking at the nerves or biomarkers.
So when I was working with Dr. Martin Klukow in Sydney, we were looking at reverse diastolic flow and size as the most important things, though we did the LAO. So how much importance do you attach to the reversal of flow?
So if you look at all the data today, that has been shown that if most of the people has treated, if there is a reverse or absent diastolic flow. But my concern is that a lot of auto-regulation happens, okay? And that's why you are not finding any result in even after treatment. So best way would be, I will continue to treat, but now we have got a facility to have a nurse. So if I will put it on the renal and mesentery, and if the saturations are well maintained, then I will say, okay, let's wait, don't jump. If the saturations in the brain is well maintained, the cerebral saturation is more than 65 and oxygen extraction is good, I will say, okay, wait for it. I presented that slide. That was a nice paper. People should read that.
So some of the questions are the same regarding the feeds and the course. A lot of concern regarding feeding and giving the treatment. We covered that. Recently, a new algorithm was published in pediatrics. It mentioned that early targeted is between 24 hours to 6 days, and infants that are symptomatic in that period should be always treated. What do you think about this management? Dr. Evrim Dizdar.
Which day? Can you repeat which day?
The question is by Dr. Evrim. Recently, a new algorithm was published which said that early targeted treatment is between the first day to the sixth day. And if the infants are symptomatic in this period, they should all be treated. What do you think about this management?
I can just answer that. You can note. If you look at the study, you can mute. You can look at the published studies and even the whatever is written in the average. Most of these babies around 28 weeks, they have a closure between 40 to 60%. So if you treat early in the first week, you will be unnecessarily over treating. I would wait till the end of 7 days to start the early treatment. But it depends on if the baby is 26 weeks and below. What you said is exactly correct. You can treat in the first few days of life. But for 27 weeks and above, treating in the first few days of life is not generally advisable. Having said that, in a patient whom I mentioned, you have a maternal, no antenatal steroids, you have to individualize the patient. It's a male sex, abruption, asphyxia, male sex, anemia. There are a lot of comorbidities. You might consider in a case to case rather than a blank algorithm, everybody should get treated below 28 weeks. So 26 weeks and below, yes, but about 26 weeks, because the closure rates are very significant. By the end of 7 days, 40 to 60% gets closed by spontaneously. And the credit of treatment, the credit of the drug getting the benefit is because of the spontaneous closure rather than the drug itself causing it.
There's a question regarding the post-ligation syndrome that we see. The question was, why do we see it less often with device closure and why is it more with actual surgical ligation?
I think the surgery is a major thing to do. You have the baby is ventilated and anything which opens the chest. There are many factors. It is not simply closing the duct or blocking with a device inside transcutaneous. A major opening the chest and many intrathoracic pressures. So many factors.
I suppose the anesthesia also, which is much
so many
longer.
things. Yeah, not only anesthesia but intrathoracic pressures. There are multifactorial.
Yeah.
So that is why it is much less in transcatheter.
I think you do see post-cardiac syndrome even with the cap, but the severity is less. The afterload reduction, increase in afterload is much less as compared to the open surgery.
It was mentioned in the slide that paracetamol will increase the mortality. Any explanation for this?
I don't think I mentioned paracetamol will increase the mortality. No,
yeah, even I don't remember seeing that.
No.
Yeah.
No, paracetamol will not increase the mortality. No, not as nobody has published that way, and neither was my presentation meant to convey that message.
Okay. I think we are coming towards the end of it. In your opinion, what is the best hematocrit and hemoglobin for baby with PDA on CPAP?
It should be around 35 to 40 or hemoglobin of at least 12 to improve the oxygen carrying capacity besides supporting the PDA. So at least 35 to 40 roughly translate to 12 gram hemoglobin. If the baby is having say below that, you might consider Paxil transfusion of 10 cc per kg to keep it around that figure.
When would you consider starting diuretics?
Diuretics is based on the X-ray findings of cardiomegaly and pulmonary edema. you might start early if it is bad one. First, you might try a stage 1. Suppose the baby is on 160 ml. The first thing to do will be fluid restriction. A short course, most of us start furosemide. Unless the baby has got severe pulmonary edema, the furosemide actually will complicate the issue and keep the duct open. And this is if you're starting diuretics, you cannot stop after 2 days. If you are in bad, baby is about to be ventilated, you might give 1 or 2 days of furosemide, but I wouldn't prefer to continue furosemide indefinitely for fear of furosemide itself causing the duct to be open. And secondly, 10 days of furosemide is enough to cause nephrocalcinosis. Most of us are not doing periodic calcium, urine calcium creatinine ratios, not even looking at ultrasounds every week, although these are recommended. And many babies are on continuous Lasix for many weeks.
What about hydrochlorothiazide?
Yeah, hydro and spiro can be given, and many people do that. But long-term furosemide, no.
Any other questions on the YouTube, Dr. Manjusha? Dr. Manjusha?
I think that is it.
Yeah.
No, madam, we don't have any more questions.
Okay. Right. Okay. Any take-home messages just to summarize within 2-3 sentences for each of you, Dr. Manoj and Dr. Prakash. And I must say it was an amazing talk. You all covered the entire spectrum, and we all could, many of us who've lived through the last 20 years in neonatology could see the entire spectrum of PDA and how it's changed and how we are still so confused at the end of it. I would like a few words from both of you, and Dr. Surya Narayan, if you want to.
Okay, I think the most perplexing thing for me is that what is the contribution of PDA into various morbidity. And I'm a bit skeptical about treating PDA in very early life. I feel there are so many other variable loading conditions which need to address first. So if your incidence of IVH is very high, then you need to address all other things, DCC, and taking care of your afterload and preload. If you decide to treat, because paracetamol has no effect on circulation, and PDA contribution in mechanistic studies is limited. So need more mechanistic study. I think bigger baby in India, I think if it is bothering you as a PDA, I will wait and watch. I will look at all other causes. That is my take.
Thank you. Dr. Prakash.
Hello.
Yeah.
Yeah, my couple of cents on this. Can you just? I would focus on before birth. I think I have mentioned it clearly. You start with make sure that most of the mothers are given antenatal steroids. The babies are taken care of well at birth. You enforce delayed cord clamping for a minute or so. Then you get the baby in a very good shape, pink, perfused, and put them on non-invasive ventilation. And these days, the amount of surfactant we are using is come down to a remarkable extent. So if there is no severe RDS, if there is no severe morbidity, these complications of prematurity are bound to come down. Secondly, don't create a new PDA. Be cautious on the fluids. The first few days of life, you are not chasing growth. You are only making the baby transition to the normal, changing from the intrauterine to extrauterine, and somehow coping with the extrauterine environment. So you might use, we are using starter treatment. The first thing IV fluid we are using is starter treatment. It's always in the fridge. And the third thing is you target asymptomatic PDA and consider in subgroups like 26 weeks and below. In case you are forced to treat, wait for at least a week before jumping to treatment. That is my take on this.
And at the end of this exhaustive lecture, what I feel is there is no algorithmic approach to PDA is not going to help. It is only there to only guide you. And many of the treatments has to be individualized depending upon the antenatal situations, prenatal situation, and then the clinical setting, and titrate it accordingly to get the best result out of this.
Yeah. Thank you.
Thank you very much.
I think Dr. Rajgopal and Dr.
Yeah.
Vishnu can take.
I'm here.
Yeah.
Respected seniors, my dear friends. Today, we had a very good interactive session on PDA in preterm infants. I, on behalf of IAP Neonatology chapter, express our sincere thanks to Dr. Prakash Manikoth and Dr. Manoj Malviya, two senior consultants from Muscat, for their excellent presentation. Thank you, sir. We express our sincere thanks to two eminent neonatologists, Dr. Preeta Joshi and Dr. Suryanarayan Nori, for moderating the session. Thanks. Our heartfelt thanks to all the delegates who attended today's program. In December webinar series, we are focusing on asphyxia and neuroprotection. The first one of it is on 5th December, 5 p.m. We request your participation. Once again, thanks to you all, and thank you.
Thank you all.
Thank you.
Thank you.
Thank you so much.
Thank you, Dr.
Thank you very
Manoj.
much. Thank you.
Thank you.
Dr. Joshi.
Thank you all.
Yeah, thank you, Manoj. Thank you.
Thank you all. Thank you.
Thank you,
Manoj and
sir.
Manoj. Bye-bye.
Bye.
Bye.
Good night.